Bismillahirrahmanirrahim. I'll start discussing with you about Cushing syndrome, what is meant by Cushing. I'm going quickly to refresh your mind with the hypothalamic pituitary adrenal axis. We shall classify Cushing syndrome according to the broadest classification of Cushing into what is known as ACTH dependent and non-ACTH dependent Cushing. And I'm going to throw a light by what is meant by the two expressions I just mentioned now. Then I'm going to discuss with you about the highly pathognomonic signs and symptoms of Cushing based on history taking and physical examination together with the suggestive manifestations of Cushing. Then we are going to shift to how to diagnose a case of Cushing, how to screen and how to localize, and ultimately how are we going to manage. So Cushing syndrome is defined as just merely elevation of cortisol in the bloodstream. That's to say that the cortisol is high and accordingly the tissues of the patient is exposed to high levels of glucocorticoids. And it's worth mentioning that the most common cause of Cushing syndrome is exogenous administration of steroids. So whenever you are going to find a patient with suggestive manifestations of Cushing syndrome, according to clinical examination and history taking, the first thing that's going to strike your mind is that the patient may be taking an exogenous source of steroid. This is why the patient is suffering from manifestations of Cushing. And let me refresh your mind with the hypothalamic pituitary adrenal axis. So we know that out of the hypothalamus there is a factor known as corticotropin releasing hormone that is going ultimately to act on the anterior pituitary basophilic cells, namely the corticotropin releasing cells, leading to the release of what is known as AP, the ACTH, the adrenocorticotropic hormone. ACTH is going to act on the adrenal gland, namely adrenal cortex. And let me remind you that the adrenal cortex is composed mainly of three main zones: the zona reticularis, the zona fasciculata, and the zona glomerulosa. The zona glomerulosa, from which arises the aldosterone, the mineralocorticoids. The zona fasciculata releases the glucocorticoid, the cortisol, while zona reticularis is responsible for the release of the adrenal sex steroids, the adrenal androgens, I mean. ACTH is mainly controlling both the zona fasciculata and the zona reticularis, and that's to say it controls the secretion of both cortisol and adrenal androgens, while ACTH has nothing to do with aldosterone secretion. Aldosterone secretion is mainly dependent on the renin-angiotensin system together with the potassium level in the blood. However, ACTH doesn't enter in the feedback regulation of aldosterone. And you know that we are having a potent feedback mechanism in our body related to all our endocrine glands, namely the negative feedback mechanism. That's to say, for instance, if I'm having a low cortisol level in the blood, the hypothalamus and the anterior pituitary, both of which they are going to be stimulated in order to increase the level of steroids, and vice versa. If the cortisol level is high, both the hypothalamus and the anterior pituitary, they are going to be suppressed, leading to suppression of the level of endogenous cortisol, or I mean endogenous adrenal secretion. This is known as negative feedback mechanism. One arrow up and one arrow down. Vice versa, inverse relation between the hypothalamus and pituitary on one hand and the target organ on the other hand. So let us shift now to the classification of Cushing. So Cushing is classified into exogenous hypercortisolism and endogenous hypercortisolism. And please, I'd like to focus that Again, the most common cause of Cushing syndrome is exogenous administration of steroid, known as iatrogenic Cushing syndrome. That's to say, it is medically induced, while endogenous hypercortisolism is a rare endocrine disorder. So according to the hypothalamic pituitary adrenal axis I just discussed with you, if I'm having a high cortisol level, I would expect either that if I'm having a high ACTH and hence the cortisol level is high, or on the other hand, the cortisol level is high regarding the level of ACTH, and accordingly, endogenous hypercortisolism is classified into ACTH-dependent Cushing and ACTH-independent Cushing. ACTH-dependent Cushing means that I'm having a high ACTH. This is why cortisol is high. And why do you think a patient may have a high ACTH? A patient may have a high ACTH because you know that ACTH is mainly released out of the anterior pituitary gland. This is why the patient may have ACTH-dependent Cushing due to the presence of pituitary adenoma. Adenoma affecting the ACTH releasing cells and hence leading to stimulation of both adrenals and leading to endogenous hypercortisolism. Most of the cases harboring pituitary adenoma leading to Cushing, hypercortisolism, is due to the presence of a microadenoma affecting the ACTH secreting cells. If I'm having a patient having what is known as pituitary Cushing, it is said to be a case of Cushing disease. So whenever we are going to mention the word Cushing disease, it means that the patient is having a case of pituitary Cushing. That's to say, it is an ACTH-dependent Cushing, most probably due to the presence of a pituitary adenoma. In most of the cases, it would be a microadenoma, almost in 80 to 90% of the cases. Why do you think other causes of ACTH-dependent Cushing? As I just discussed with you now that ACTH is mainly released out of the anterior pituitary, but do we have other signs for our release of ACTH? And simply the answer is no. And if I'm having a cell releasing ACTH, it won't be a normal cell, it would be a neoplastic cells. A neoplastic cell releasing a substance like hormone, releasing a substance which is not normally released out of this cell. So it is transformed into a neoplastic cell. So in cases of a paraneoplastic syndrome, I may have an ectopic ACTH secretion, and in a very, very rare case, I may have ectopic CRH secretion. If I'm having an ectopic ACTH secretion, it will lead to stimulation of both adrenals releasing excessive levels of cortisol. And what are the main causes of ectopic ACTH secretion, or in other words, what are the main tumors or the most common tumors leading to ectopic ACTH secretion? They are small cell carcinoma of the lung, pancreatic tumors, carcinoid. However, theoretically, ACTH may be arising from any endocrine tumor all over the body. Ectopic CRH secretion, as I just mentioned, is a very, very rare disorder, and cases reported with ectopic CRH are scattered case records all over the world. On the other way along, cases of ACTH-dependent Cushing, let us replace the word ACTH-independent Cushing by cortisol is high regardless of the level of ACTH. That's to say, cortisol is high despite ACTH is low. And whenever I'm going to find this disorder, I'm going to think of the adrenal gland. The adrenal gland is releasing excessive levels of cortisol, and cause the hypothalamus and pituitary, they are normal and intact, they are healthy. They are going to respond by suppression of the level of both CRH and ACTH, leading to suppression of ACTH in the setting of a high cortisol level. And causes of adrenal Cushing entails unilateral adrenocortical adenoma, unilateral adrenocortical carcinoma, in very rare cases, bilateral adrenal adenomatosis, either micro or macronodal. And these disorders they are quite very rare disorders. The most common cause of adrenal Cushing is said to be unilateral adrenal adenoma, and the most common cause of endogenous hypercortisolism is Cushing disease, and the most common cause of Cushing syndrome is exogenous hypercortisolism or iatrogenic Cushing. So now we are going to discuss about the highly pathognomonic signs and symptoms of Cushing syndrome based on history taking and physical examination, together with other suggestive features of Cushing syndrome. Cushing syndrome may be presented with various signs and symptoms. However, what I'm going to discuss with you right now, and they are said to be the highly pathognomonic signs and symptoms of Cushing, the patient is likely to be a case of Cushing, and you must not leave your patient without screening. Whenever you're having a patient presented with these manifestations, this patient warrants screening. The highly pathognomonic signs and symptoms of Cushing, there are 5 signs and symptoms. 3 are mucocutaneous manifestations and 2 are musculoskeletal manifestations. The first mucocutaneous manifestation, it was as known as striae. And striae in the setting of Cushing syndrome, those pathognomonic of Cushing, are said to be reddish purplish wide depressed striae. Reddish purplish wide depressed striae. They're reddish purplish in color. They're wide, their width exceeds 1 centimeter, and the skin overlying is depressed. It is reddish purplish in color because the presence of striae entails that the skin is stretched, and whenever the skin is going to be stretched, the elastic tissue there would be minute hemorrhage in the capillaries leading to reddish purplish discoloration. However, by the formation of fibrous tissue, the reddish purplish striae should be turned into white color, striae alba. However, in cases of Cushing syndrome, because cortisol is a catabolic hormone and it stimulates the breakdown of fibrous tissue, the striae will remain to be reddish purplish in color and will never turn into alba unless the patient is cured. White is having depressed skin overlying, because again cortisol is a catabolic hormone leading to destruction of the collagen layer of the skin and leading to thinning of the skin together with depression of the skin overlying. The second mucocutaneous manifestation is facial plethora. And what is meant by facial plethora? It means reddish discoloration of the skin. Again, steroids, they are catabolic hormones leading to destruction of the collagen layer of the skin, thinning of the skin, and reflection of the underlying vessels, together with the induced polycythemia in cases of Cushing syndrome due to high levels of steroids, leading to the reddish appearance of the face. The third mucocutaneous manifestation is easy bruising, multiple ecchymotic patches without a history of obvious trauma. The patient reports the presence of multiple ecchymotic patches and easy bruising without a history of a trauma preceding the bruising. The 2 musculoskeletal manifestations are said to be proximal muscle weakness affecting the proximal muscles, and the patient may come complaining of, I can't climb upstairs well, I can't lift up from a sitting position, I can't comb my hair, I can't lift my arm in order to bring something from a high position, because the patient is mainly complaining of proximal muscle weakness. The last highly pathognomonic sign and symptom of Cushing, and the second musculoskeletal manifestation of Cushing, is unexplained osteoporosis. And mind you that Cushing syndrome is one of the top causes, endocrine causes of osteoporosis. We're having a large entity of cortisol-induced osteoporosis. We do see a lot of cases in clinical practice suffering from osteoporosis secondary to Cushing syndrome and mainly due to iatrogenic Cushing, as I mentioned before. These manifestations are said to be the highly pathognomonic signs and symptoms of Cushing. If you are confronted with a patient having Cushing syndrome in childhood, that's to say juvenile Cushing, you would expect that the patient would have excessive weight gain together with without associated increase in body height. That's to say that the patient is gaining weight and not gaining height appropriately when you are going to follow with the growth velocity. The growth velocity, which is the best sensitive indicator of growth in childhood period. So let me show you some photos of the highly pathognomonic signs and symptoms of Cushing. This is a man having Cushing syndrome. Could you notice the multiple ecmotic patches the patient is experiencing and the facial plethora as well? The stria, reddish purplish white stria. The common signs for the appearance of stria are the size of the abdomen, buttocks, size of the breasts, shoulders, inner aspects of arms and thighs. Another case with Cushing with the facial plethora and the highly pathognomonic signs and symptoms of Cushing. A female patient who developed Cushing syndrome, as you could see here, that is suffering from facial plethora and pigmentation in her face. And why do you think a patient with Cushing syndrome may have pigmentation? And does it denote that the patient is having an ACTH dependent Cushing or non-ACTH dependent Cushing on clinical basis? And simply the answer that you know that ACTH is released out of the anterior pituitary from a mother cell known as pro-opiomelanocorticoin. And from this mother cell, ACTH and MSH, the melanocyte stimulating hormone, both of them, they are released in equimolar amounts. So whenever we're having high levels of ACTH, we would expect high levels of MSH associating. This is why if I'm going to find a patient with suggestive manifestations of Cushing and may find pigmentation associating the features, it may denote that the patient is suffering from ACTH-dependent Cushing. And if the pigmentation is too prominent, it may entail that the patient may have an ectopic ACTH production, because in cases of ectopic ACTH production, ACTH levels are very high. There are sky-high levels of ACTH leading to excessive pigmentation. A child with a juvenile Cushing, could you see the facial plethora and the weight gain without associated increase in body height? Then how are we going to approach to a case of Cushing? We shall approach from the early beginning based on history taking and physical examination on the highly pathognomonic signs and symptoms of Cushing and the other suggestive manifestations of Cushing. Starting the diagnostic approach, and please concentrate in this statement. This statement is the recommendation of the Endocrine Society, the top endocrine association all over the world, from which most of our guidelines in our endocrine practice we are adopting from. Endocrine Society recommends obtaining a thorough drug history from a patient with suggestive manifestations of Cushing in order to exclude exogenous glucocorticoid exposure leading to iatrogenic Cushing. So that's to say, if you are having a case of Cushing syndrome, before starting your workup, before starting the stepwise approach of the lab workup, please take a very thorough drug history from your patient. If your patient is taking an exogenous source of steroids, it is the most common cause of Cushing syndrome, whatever the route: oral, parenteral, rectal, topical, and inhaled steroids, all of which may end up with Cushing syndrome. It does differ according to the potency of the steroid intake taken, the dose, the route of administration, the duration of its administration. If the patient is having concomitant medication, that may prolong its half-life. And we should ask ourselves a very important question: who should be tested for Cushing? It is recommended that Cushing syndrome should be tested in the following groups. If the patient is having highly pathognomonic signs and symptoms of Cushing I just discussed with you, reddish purplish white depressed striae, facial plethora, easy bruising and multiple ecmotic patches without previous or after a minimal trauma, proximal muscle weakness, and unexplained osteoporosis. And if I am having a child with decreased height percentile, increasing weight, that's to say he's gaining weight well and he's gaining excessive weight without associated increase in body height. Patients with suggestive or predictive manifestations of Cushing. And what are the suggestive manifestations of Cushing? As I told you, there are various manifestations. There are multiple manifestations suggestive of Cushing. Secondary hypertension, that's to say hypertension with a cause, and most probably it occurs in young age. Poorly controlled diabetes or worsening of the diabetic status. Psychiatric disorders. Mind you that Cushing syndrome is one of the endocrine disorders associated with psychosis. Hirsutism in females, menstrual irregularities. It may lead to secondary polycystic ovary syndrome. Gastritis not responding to medications. So we are having a lot of manifestations that may be related and may be suggestive of Cushing. If you're having a patient with highly pathognomonic signs and symptoms of Cushing, you are not free to choose. You must screen for Cushing. However, if you're having a patient with suggestive features of Cushing, it is based on your clinical index. If you are suspecting that this case of Cushing, you may go for a screening. However, it is left for your clinical judgment. The last group of patients that you should screen for Cushing, those patients presented with what is known as adrenal incidentalloma. And what is meant by adrenal incidentalloma? Adrenal incidentalloma means accidental discovery of adrenal mass by imaging study, not related or not performed due to adrenal cause. And let me give you an example. If you're having a patient with chronic abdominal pain and you ordered a CT scan on the abdomen in order to find the cause for his chronic abdominal pain, and while you are searching, you found an accidental discovery of an adrenal mass. So this is an adrenal mass discovered accidentally by CT scan, which is an imaging study, and it is performed due to the chronic abdominal pain. That's to say it is for a cause unrelated to adrenal lesions. And this is coined to the definition of adrenal incidentalloma: accidental discovery of adrenal mass by imaging study performed for a cause unrelated to the adrenal glands. These are the four group of patients that should be tested for Cushing. These are the highly pathognomonic signs and symptoms of Cushing, and all these are the suggestive manifestations of Cushing. Then we are going to shift to the lab workup, the biochemical evaluation. And let us agree that biochemical evaluation for Cushing syndrome and of most endocrine disorder precedes the imaging evaluation. So whenever you're having an endocrine disorder, start by biochemical evaluation before jumping into imaging localization. In our biochemical evaluation, we are going to follow a stepwise approach. The stepwise approach means that in step 1, we are going to ask ourselves an important question. Is it a case of Cushing? That's to say, we are going to screen our patient. Is the patient with suggestive manifestation of Cushing? Is it a true case of Cushing, yes or no? And if the answer of the first question turns back to be yes, it is suggestive to be a case of Cushing, it is a case of Cushing, we are going to go to step 2, which is localization of Cushing. We need to reach the cause. Is it a case of Cushing disease? Is it a case of abnormal Cushing? Or it is a case of ectopic Cushing? So first of all, we need to reach, is it a true case of Cushing, yes or no, by step 1? And then by step 2, we are going to localize. 3 main pathophysiological arrangements are beyond the concept for biochemical evaluation of Cushing. First of all, the first biochemical derangement that occurs in Cushing syndrome is loss of the normal diurnal variation. You know that cortisol level, they are very high in the morning, very low in the evening, according to the normal circadian rhythm. In cases of Cushing syndrome, there is loss of the normal circadian rhythm. That's to say, the cortisol level at night is higher than that in the morning. However, the mere evaluation of cortisol level at the morning and at the evening is not considered to be a screening test for Cushing, because sometimes we may be confronted with night shift workers, and in these cases, normally the circadian rhythm is inverted, despite these cases are not cases of Cushing syndrome. So don't depend upon evaluation of cortisol both at the morning and at the evening in order to search for the loss of circadian rhythm to screen for Cushing. It is not considered to be a screening test for Cushing because sometimes in normal individuals it may be inverted. The second concept is loss of the normal physiological controller, loss of the feedback mechanism. You know that according to the feedback mechanism, if I'm having a high cortisol level, ACTH should be suppressed, and accordingly the endogenous cortisol should be suppressed. In cases of Cushing syndrome, if I'm going to offer a patient an exogenous source of steroid because the patient is having an endogenous source of hypercortisolism, they won't respond to the normal feedback mechanism. And I'm going to explain thoroughly to you in the next couple of slides. The last concept is dependent upon the concept that cortisol level would be high in its free form, both in urine and in saliva. Accordingly, we are having 4 screening tests for Cushing adopted from most of the endocrine association. And any test apart from these 4 screening tests for Cushing is not considered to be a screening test for Cushing. Accordingly, if you are suspecting a case of Cushing, don't order a basal cortisol level at 9 a.m., between 8 and 9 a.m. Based on the idea, if the patient is having Cushing syndrome, we would expect that cortisol level would be high. No. Please mind you that a normal cortisol level, a normal basal cortisol level doesn't exclude Cushing syndrome, and a high cortisol level doesn't confirm the presence of Cushing syndrome. So, accordingly, a high basal cortisol level is not a confirmatory screening test for Cushing. We do order basal cortisol level at the morning from 8 to 9 a.m., but we are going to do so only in order to exclude exogenous causes of Cushing syndrome, iatrogenic Cushing. Because if the patient is taking an exogenous source of steroids, say for instance prednisolone, and you estimate cortisol at the early morning, would expect that the cortisol level would be too low, because according to the feedback mechanism, CRH and ACTH, both of them, they are going to be suppressed, and they are going to suppress the endogenous cortisol. And we are measuring the endogenous cortisol. This is why the patient is receiving an exogenous source of steroid, the cortisol is expected to be too low. So if you are having a patient with a full-blown picture of Cushing syndrome and you found that the cortisol level, basal level at the morning is low, it is a straightforward case of iatrogenic Cushing, and you needn't continue the workup. You can't help the patient in anything as an endocrinologist. What you are going to do, you are going to ask the treating physician to withdraw steroids if the patient is not dependent on steroids for controlling of his disease. So again, basal cortisol level at the morning is not considered to be a screening test for Cushing, and we only perform this test to exclude the presence of low levels of steroids, to exclude the iatrogenic Cushing syndrome, and not to confirm or not searching for high levels of steroids or cortisol level. These are the 4 screening tests for Cushing: 24 hours urinary free cortisol, late night salivary free cortisol, the 1 milligram, or in other words, the overnight dexamethasone suppression test, and the low dose dexamethasone suppression test. And let me explain for you the concepts of these tests. The 24 hours urinary free cortisol entails that the patient is coming to collect urine all over the 24 hours. Normally, cortisol resides in urine in its free form. So if the patient is having an endogenous source of hypercortisolism, we may expect that the patient will have increased free levels of cortisol in his urine among the 24 hours. So we're going to ask the patient to collect his urine for all over the 24 hours, discard the first voided urine at the morning, then collect urine all over the day and include the next morning sample of urine. If the result turns back to be 3 times the upper limit of normal, this patient is considered to have a positive screening test for Cushing. So the interpretation of a positive 24 hours urinary free cortisol entails the presence of a level which is 3 times the upper limit of normal. The midnight salivary free cortisol level is based on the concept there is a loss of circadian rhythm together with a presence of a high level of free cortisol in saliva. What we are going to do in this test, despite it is not available in Egypt because the kits responsible for measurement of cortisol in the saliva, they're not available in Egypt, we are going to ask the patient to collect his saliva at the midnight where we expect the cortisol level to be too low, and we are going to estimate the cortisol level in the saliva where it is present in its free form. If the result turns back to be twice the upper limit of normal, it is a positive screening test for Cushing. But as I told you, this test is not available in Egypt and in most centers in Europe. It is widely available both in States and in India. The low-dose dexamethasone suppression test and the overnight dexamethasone suppression test, both of them, they are having the same concept, which is loss of the negative feedback mechanism. In the overnight dexamethasone suppression test, what we are going to do, we are going to offer patients a 1 milligram dexamethasone at night from 11 to 12 p.m. and then we are going to measure cortisol at the next morning from 8 to 9 a.m. If the cortisol level is suppressed beyond a certain cutoff level, it is set to exclude this patient to be a case of Cushing. While if the patient is exceeding a certain cutoff level, it is said to be a positive screening test for Cushing. So again, give a patient 1 milligram of dexamethasone at night from 11 to 12 p.m. Measure cortisol next morning from 8 to 9 a.m. If the cortisol level is suppressed less than 1.8 Ug per deciliter or 50 nanomole per liter, this patient is excluded to be a case of Cushing. While if it is more than or equal 1.8 Ug per deciliter or 50 nanomoles per liter, it is said to be a positive screening test for Cushing. So the interpretation of this test is unsuppressible cortisol level post-dexamethasone. Here we do depend on a known cutoff level, which is 1.8 Ug per deciliter or 50 nanomoles per liter. The low-dose dexamethasone suppression test is more sophisticated. It is set to give the patient 0.5 mg of dexamethasone every 6 hours over the course of 2 days. Give the patient 1 tablet of 0.5 mg of dexamethasone every 6 hours at day 1. At day 2, you are going to give the patient again 0.5 mg every 6 hours, and then next morning after the 2 days, you are going to measure the cortisol level from 8 to 9 a.m. If it is less than 1.8 Ug per deciliter, diagnosis of Cushing syndrome is excluded, while if it is equal or more than 1.8 Ug per deciliter, it is said to be a positive screening test for Cushing. Accordingly, how are we going to interpret or how we are going to decide according to the available screening test for Cushing? If you are having a positive screening test, you need to confirm by another test. If you are having a negative screening test, it will be based upon your clinical suspicious. If you are having a high clinical suspicious index, you may choose another screening test. If you don't have a high clinical suspicious index, you are free to let the patient go and exclude the diagnosis of Cushing. So, if you are suspecting a case of Cushing, first of all, exclude exogenous glucocorticoid administration. Perform one of the 4 screening tests for Cushing, either 24 hours urinary-free cortisol, overnight 1 mg dexamethasone suppression test, or midnight salivary-free cortisol. If one of these tests turns back to be positive, you should screen by another test. And most probably, low-dose dexamethasone suppression test would be resorted as a second confirmatory test because, as I told you, it is somehow sophisticated. If you are having 2 positive screening tests, you are allowed to go to step 2, which entails localization. If you are having a negative test, it will be based upon your clinical suspicious index, either to proceed to another screening test or to stop your workup at this point. Why do we need 2 separate positive screening tests? Because we're having an entity, what is known as pseudo-Cushing. You may have a false positive test while the patient is not a true case of Cushing. And what are the main causes of pseudo-Cushing? Obesity, pregnancy, use of certain antipsychotics, chronic alcoholic use, chronic liver and chronic kidney diseases. This is why we need 2 positive screening tests for Cushing in order to proceed to step 2. And as I told you, step 2 entails localization. In step 2, we are going to use 2 tests. The high-dose dexamethasone suppression test. So mind you that the high-dose dexamethasone suppression test is only used as a localization test in cases with positive screening tests for Cushing. The idea in high-dose dexamethasone suppression test, we are going to offer patients a higher doses of steroids capable of suppression of the axis if the cortisol level is expected to be mildly to moderately elevated, and while this test is unable to suppress the cortisol level if cortisol is expected to be high or too high levels. And when do you expect cortisol to be mildly to moderately elevated? It is expected to be found in cases of pituitary Cushing. However, in cases of ectopic and adrenal Cushing, cortisol levels are expected to be too high. So in other words, high-dose dexamethasone suppression test will be able to suppress the axis if the case is a case of Cushing disease, while if the case is a case of adrenal Cushing or ectopic Cushing, they won't respond to the high-dose dexamethasone suppression test. Here, in contrary to the concept of the low-dose dexamethasone suppression test, we won't depend on a certain cutoff level. We would depend on comparison of cortisol level post-administration of high doses of dexamethasone as compared to levels pre-administration of high dose. And let me tell you how are we going to perform this test. We are going to measure cortisol, a basal level of cortisol from 8 to 9 a.m. in day 1. Then you are going to offer your patient high doses of dexamethasone, 2 mg every 6 hours for 2 days. Let me remind you that in low-dose dexamethasone suppression test, we used 0.5 mg every 6 hours. Here we used 4 times the dose used in the low dose, 2 mg every 6 hours for 2 days. For the first day and for the second days, 2 mg every 6 hours, 8 mg the first day, 2 mg every 6 hours in day 2, 8 mg the second day, with a total of 16 mg in high-dose dexamethasone suppression test as compared to 4 mg in low-dose dexamethasone suppression test. In the next morning, after the elapse of the 2 days, we are going to remeasure cortisol from 8 to 9 a.m. And here we are having two levels. Cortisol pre-high dose and cortisol level post-high dose. A pre-cortisol level and a post-cortisol level. I mean pre to high dose administration and post to high dose administration. If the cortisol level post-high dose administration is suppressed more than 50% as compared to the test or pre-high dose administration, it is said to be a case of pituitary Cushing, while if it is suppressed less than 50% of the pre-test level, it is said to be either a case of adrenal or ectopic Cushing. Let me give you an example. If the patient is having his basal cortisol level pre-administration of high dose is said to be 42, and post high dose dexamethasone suppression test it is said to be 12. So 42, the 50% of which would be 21. So if it is more than 50%, it's said to be a case of Cushing disease, while if it is less than 50%, it is said to be a case of either adrenal or ectopic Cushing. In cases of, in our case, it was 42, and then after the test it is 12, so it is a case of Cushing disease. How am I going to differentiate between adrenal and ectopic Cushing? By estimation of the ACTH level. If it is if the ACTH turned back to be low level, it is said to be a case of adrenal Cushing. As I told you, it is an ACTH independent Cushing. The cortisol level is high while the ACTH is low, because the pituitary here is intact and healthy. While in cases of ectopic Cushing, it is said to be a case of ACTH dependent Cushing, where we do expect ACTH here to be elevated to a great extent, sky-high levels of ACTH. And hence, we reach the cause of Cushing syndrome based on biochemical evaluation. Here we are left with imaging evaluation of Cushing syndrome, and this will be dependent on the interpretation of the biochemical evaluation by step 2. So step 2 starts by biochemical evaluation, and then we are going to go to imaging localization accordingly. If I'm having a case of Cushing disease, we are going to order the best imaging modality for Cushing disease, which is MRI on the sella turcica with gadolinium, with dye, I mean. If it is a case of adrenal Cushing, we are going to order CT scan on the abdomen. If it is a case of ectopic Cushing, we would order CT scan on head and neck, chest, abdomen, and pelvis, or a PET scan in order to reach the primary source of malignancy. So according to the interpretation of the biochemical evaluation of step 2, we are going to go accordingly to imaging evaluation. Could you remember when I told you that most cases of Cushing disease is due to the presence of pituitary microadenoma affecting ACTH secreting cells? And in most of the cases, or let me tell you, it is around the figure of 40%. When we are going to perform MRI salivary scan in these cases suspected to have Cushing disease, we won't be able to find the lesion based on MRI. And here we may have another invasive modality for diagnosis of Cushing disease, which is known as inferior petrosal sinus sampling. And in the concept of inferior petrosal sinus sampling, it is considered to be the gold standard in differentiating cases of pituitary Cushing versus ectopic Cushing. However, it is an invasive technique and we don't resort to unless we may find that the case is MRI negative and the case is suspected to be a case of Cushing disease. So let me revise with you the workup. If you are going to suspect Cushing, you are going to go for a screening after the very important step, which is exclusion of any exogenous source of steroid intake. You may use one of the 4 screening tests: 24 hours urinary free cortisol, late night salivary free cortisol, or 1 milligram overnight dexamethasone suppression test, and most probably low dose would be resorted as the second confirmatory step. If it turns back to be negative, depend on your clinical suspicious index either to proceed or to stop. If it turns back to be positive, we need another positive screening test. If we are having 2 positive screening tests, we are going to go to step 2, which is localization. And here we are going to use high-dose dexamethasone suppression test. If it is suppressed more than 50% of the basal level, it's said to be a case of pituitary Cushing. If it is suppressed less than 50%, it is either a case of adrenal or ectopic Cushing, and you are going to differentiate by the estimation of ACTH. In cases of Cushing disease, you are going to order MRI. If it turns back to be negative or you can find the lesion, you are going to proceed to bilateral inferior petrosal sinus sampling. In cases of adrenal Cushing, you are going to proceed to CT scan. In cases of ectopic Cushing, either perform PET scan or a CT all over the body, head and neck, pelvis, abdomen, and chest in order to reach the primary source. Accordingly, how are you going to treat Cushing syndrome? The definitive treatment of Cushing syndrome is surgery. So surgery is the primary therapy for all causes of Cushing syndrome. However, we may find that some cases they are ineligible for surgery, or they are considered to be inoperable cases, and they're said to be present in cases with either adrenocortical carcinoma or in cases with ectopic Cushing, where the life expectancy of the patient would be too limited and the prognosis is said to be, unfortunately, too low. The prognosis is said to be too bad, unfortunately, in such cases. Here, surgery we do rarely resort to unless debulking and to be followed by either radio or chemotherapy. However, we don't commonly resort to surgery in such cases, and we do resort to surgery in other common causes of Cushing, namely Cushing disease due to the presence of pituitary microadenoma or unilateral adrenocortical adenoma by laparoscopic adrenalectomy. Preoperatively, you need to control the associated comorbidities, give your prophylaxis against peptic ulcer, and cover with broad-spectrum antibiotics because your patient would be severely immunocompromised due to high levels of steroids, where Cushing disease, the optimum surgery would be transsphenoidal pituitary adenectomy, and transsphenoidal approach is said to be the best approach, associated with low rates of associated morbidities. And as I told you, most of the cases of microadenoma of the pituitary adenomas would be microadenomas very accessible by transsphenoidal approach. In cases of unilateral adrenocortical adenoma, the most common cause of adrenal Cushing, we would resort to adrenalectomy, unilateral adrenalectomy, either laparoscopic or surgical, according to the size of the adenoma and according to the experience of the surgeon. Medical treatment is there, however, we don't commonly resort to medical treatment unless it is considered to be a pre-treatment step before pituitary surgery or before adrenal surgery, a bridging therapy after pituitary irradiation, or in inoperable cases in cases of ectopic Cushing or adrenocortical carcinoma. Medical treatment used either to inhibit adrenal steroidogenesis or to modulate ACTH release or to antagonize cortisol at the level of the receptors. So these are the three main groups of medication that we may use in cases of Cushing syndrome. The most commonly and widely available medications or drugs, they are used to inhibit adrenal steroidogenesis. They are said to be ketoconazole, mitotane, and methylrobone, the three commonly used drugs. They are not available in Egypt. Ketoconazole is said to be an antifungal medication, the most common side effect of which would be elevation of the liver enzymes, as we are a hyperendemic area and we are having a lot of cases with chronic liver diseases. Ketoconazole was withdrawn from the Egyptian market because of its common associated side effect. Mitotane and methylrobone, they are expensive medications. They are not used and they are not widely available in Egypt, and they are associated with high rates of side effects. However, they could be resorted to in cases, in inoperable cases of Cushing syndrome. Drugs that may modulate ACTH release include either dopaminergic agonists, namely bromocriptine and cabergoline, somatostatin analogues, octreotide analogues. The commonly used is what is known as basirutide, or serotonin antagonist, the cyproheptadine. The cortisol receptor antagonist is mifepristone, and it will antagonize cortisol at the receptor level. But I like to focus and I'd like to stress upon the fact that the primary therapy for Cushing syndrome is surgery and not drug therapy. Drug therapy, they're not only used in limited circumstances. And by the end of this slide, I think we nicely covered all aspects related to Cushing syndrome, including the definition of Cushing, how are you going to classify what is meant by ACTH and non-ACTH dependent Cushing, what are the highly pathognomonic signs and symptoms of Cushing, how are you going to approach the case of Cushing, how are you going to start your workup from the early beginning, from the history taking and physical examination. Very important to exclude exogenous sources of steroid administration. Use proper screening tests. The four screening tests I just mentioned, they are said to be the only adopted screening tests for Cushing. Basal cortisol level in the morning is not considered to be screening test for Cushing, despite that the first biochemical derangement of Cushing syndrome is loss of circadian rhythm. The estimation of cortisol level both at the morning and at night, they are not considered to be a good screening test of Cushing because it could be normally inverted. If you're having two positive screening tests in step 1, which entails screening, go to step 2 to localize first biochemically and then by imaging techniques, and then you are going to manage your patient. And the top and definitive treatment of Cushing syndrome will be mainly surgery. And at the end, I'd like to thank you and good luck.